At 2:47 in the morning, I received a call that I have thought about many times since. A colleague from the neurology unit. A patient had come in overnight, a 71-year-old woman. No prior stroke history, blood pressure reasonably managed, no atrial fibrillation, no obvious acute trigger. She had gone to bed that night feeling completely normal. Her husband found her when she did not come down for breakfast. The neurologist called me because of her cardiovascular history. We reviewed everything together. Her medications, her readings, her recent scans. We were looking for the cause, the identifiable, measurable clinical event that had set this in motion while she slept. What we kept returning to, what neither of us could fully resolve from the data available, was the role of the 8 hours she spent in bed before the event. Specifically, the position she had slept in for years, every night, without variation, without anyone ever asking. Nobody had ever asked. I want to ask you that question today, because what happens to your brain, your blood vessels, and your cerebrospinal fluid drainage system during the hours you sleep, and how profoundly the position of your body influences all three, is one of the most significant and most completely ignored conversations in senior cardiovascular and neurological care. Tonight, that changes. I'm Dr. Ryan Foster, cardiologist, with more than 20 years of clinical experience treating adults navigating cardiovascular and cerebrovascular disease. Sleep is not passive. I want you to understand that completely before we go any further. While you sleep, your brain performs essential maintenance work that it literally cannot complete while you are awake. Your cardiovascular system undergoes pressure cycling that determines vessel health. Your lymphatic drainage system, specifically the glymphatic system, the brain's waste clearance network, operates at its highest capacity exclusively during deep sleep. Every one of these processes is directly influenced by body position, not slightly influenced, significantly, measurably, and in some cases critically influenced. And for adults over 60 whose cerebrovascular compliance has declined, whose blood pressure regulation during sleep is already more fragile, and whose glymphatic function is naturally less efficient than it was at 40 position during sleep, is not a comfort preference. It is a clinical variable, one that has never once appeared on a standard medical intake form. Here is the core problem. Your neurologist manages your stroke risk factors: blood pressure, atrial fibrillation, cholesterol, clotting. Your cardiologist manages your cardiovascular profile. Your primary care physician coordinates both. Not one of those conversations in the overwhelming majority of clinical encounters includes a single question about sleep position. This is not negligence. Sleep position exists in a clinical blind spot created by the boundary between neurology, cardiology, and sleep medicine. Each specialty sees its piece. Nobody owns the intersection. And that intersection, the relationship between sleep position, nocturnal blood flow dynamics, glymphatic drainage, and cerebrospinal fluid circulation, is precisely where a quiet, significant, and modifiable stroke risk factor lives for millions of adults over 60. Tonight, you are going to understand that intersection completely, and you are going to know exactly what to do with it. There are 3 physiological systems affected by sleep position that are directly relevant to stroke risk in adults over 60. I want to walk you through each one clearly. System 1: cerebrovenous drainage. Your brain continuously produces cerebrospinal fluid and requires continuous venous outflow to maintain stable intracranial pressure. The primary venous drainage pathway from the brain runs through the internal jugular veins, large vessels that run alongside each side of your neck. When you sleep on your back flat, supine, with your head level with your body, gravity provides relatively even drainage from both sides simultaneously. Intracranial pressure remains stable. Cerebral venous outflow is unimpeded. When you sleep on your right side specifically, the compression and positional collapse of the right internal jugular vein shifts the entire drainage burden to the left side. Studies using ultrasound have documented this drainage asymmetry in right side sleeping, and the consequence is a measurable increase in intracranial venous pressure. For a brain with healthy, flexible cerebral vasculature, this asymmetry is manageable and temporary. For a brain in a body over 60 with reduced cerebrovascular compliance, stiffer vessel walls, and existing small vessel disease, sustained nocturnal elevation in intracranial venous pressure is a physiological insult occurring every night, every hour, without a single visible symptom. System 2: the glymphatic system. This is the one that surprises people most consistently, and it is the one with the most rapidly growing body of research behind it. The glymphatic system is your brain's dedicated waste clearance network. During deep sleep, the spaces between brain cells expand, and cerebrospinal fluid is pumped through those spaces. flushing out metabolic waste products. The most clinically significant of these waste products, for cardiovascular and neurological purposes, are amyloid beta and tau proteins, both directly implicated in vascular dementia and cerebrovascular disease progression. Here is what the research has established with striking consistency. Glymphatic clearance is significantly more efficient when sleeping on the side compared to sleeping on the back or stomach. Specifically, lateral sleeping with the left side favored produces the most efficient waste clearance and the most favorable intracranial pressure dynamics simultaneously. System 3. Nocturnal blood pressure and cerebral perfusion. When you sleep on your back, the weight of the body and any degree of airway restriction, including partial obstruction that occurs without a full sleep apnea diagnosis, can create brief, repeated desaturation events that drive transient blood pressure spikes throughout the night. For a brain already managing stiffened cerebral vessels, repeated nocturnal pressure spikes during back sleeping represent repeated mechanical stress applied to vessel walls that have less capacity to absorb it than they once did. Left-lateral. Sleeping on your left side reduces the mechanical compression of the airway. It reduces positional obstruction. It supports more stable nocturnal oxygen saturation and more consistent nocturnal blood pressure. 3 systems, 3 distinct mechanisms, all pointing in the same direction. Let me give you a direct clinical example from my own practice. A patient, 66 years old, male, history of well-controlled hypertension, and a single minor TIA, a transient ischemic attack. A brief stroke-like episode, 18 months prior. No recurrence. Medications optimized. He was doing well by every standard measure. At a routine follow-up, almost as an afterthought at the end of our appointment, I asked about his sleep. Not his duration, not his quality, specifically his position. He thought for a moment and said he had always slept on his back, since childhood, every night. I referred him for an ambulatory blood pressure study with overnight monitoring. His daytime readings were excellent. His nocturnal readings showed repeated pressure spikes, irregular, unpredictable, occurring throughout the overnight hours. His dipping pattern was absent. His morning surge was significant. We did not change his medication, we changed his position. Over 3 months with positional training, a supportive pillow arrangement, and consistent sleep tracking, he transitioned to predominantly left-lateral sleeping. His follow-up ambulatory study showed a dramatically improved nocturnal profile. Dipping pattern restored. Morning surge attenuated. Same drugs, same doses, different position. Measurably different nighttime cardiovascular profile. The research supporting lateral, and specifically left-lateral sleep position for cerebrovascular protection, is not a collection of fringe observations. Studies examining glymphatic clearance have consistently demonstrated that lateral sleeping produces significantly greater waste clearance efficiency than supine or prone positions, with some research suggesting the difference in clearance rate between lateral and supine sleeping approaches, 25%. Research examining nocturnal blood pressure profiles and sleep position has found that supine sleeping is independently associated with more frequent nocturnal hypertensive episodes and greater morning surge magnitude in adults with existing hypertension, both of which are established independent predictors of stroke and cardiovascular events. Among adults over 65 with a history of TIA or minor stroke, studies suggest that positional sleep interventions, simply modifying sleep position, can contribute to improved nocturnal blood pressure profiles without any change in medication. And yet surveys of senior cardiovascular and neurology patients consistently show that fewer than 10% have ever been advised about sleep position by any member of their healthcare team. The evidence exists. The conversation does not. 3 things in your current sleep setup that may be silently working against the protective position every single night. The first is an unsupportive pillow height when side sleeping. Sleeping on your side with a pillow that is too flat or too thick causes lateral neck flexion, bending the neck sideways. This partial compression of the jugular vein on the lower side partially recreates the drainage asymmetry that right side or back sleeping produces. Pillow height should maintain a neutral cervical spine, ear aligned directly over the shoulder, not lower, not higher, level. The second is sleeping with your arm under your head, extremely common, feels natural. But the arm positioned under the head during left lateral sleeping elevates that shoulder into the neck space and creates rotational compression of the neck vessels that a pillow of appropriate height would otherwise prevent. Position your lower arm forward and slightly extended, not beneath your head. The third is unrestricted positional rolling during the night. You may begin the night in the correct position and rotate fully onto your back within the first sleep cycle, spending 6 of your 8 hours in a supine position without knowing it. Simple, inexpensive positional aids, a body pillow behind the back, a rolled towel sewn into the back of a sleep shirt are established clinical tools used in sleep medicine specifically to maintain lateral positioning throughout the night. You cannot manage a position you are not aware of maintaining. 3 specific requests for your next appointment. 1. Ask for an ambulatory blood pressure monitor specifically reviewed for nocturnal position-related spikes. Bring your sleep position history to that appointment. Tell your doctor how you sleep. Make it part of the clinical conversation. 2. If you have any history of TIA, minor stroke, small vessel disease, or poorly controlled nocturnal blood pressure, ask specifically about a sleep study that evaluates positional airway dynamics, not just apnea diagnosis. Partial positional obstruction without a full apnea diagnosis is frequently missed and frequently treatable. 3. Ask about your glymphatic health in the context of your cardiovascular risk profile, specifically whether positional sleep optimization has ever been discussed as part of your stroke prevention strategy. If your physician is unfamiliar with glymphatic research, that is not a criticism. It is a prompt for a conversation that the research now fully supports. Exactly how to begin transitioning to left lateral sleeping safely, comfortably, and in a way that maintains position through the night. Week 1. Begin each night consciously in the left lateral position. Do not attempt to force the full night. Simply start there. Allow natural rolling without resistance. Week 2. Add a standard body pillow positioned along your back. This creates a passive physical barrier to rolling supine without restricting natural movement. Week 3. Evaluate your pillow height. Lying on your side, your ear should be directly level with your shoulder. If your pillow is compressing your neck downward or propping your head upward, adjust. Memory foam pillows designed specifically for side sleeping provide consistent, adjustable cervical support. Ongoing. If you have a partner, ask them to observe your position during the first hour of sleep. That brief observation, done twice in the first week, will tell you more about your actual sleeping position than any self-assessment. This protocol requires no prescriptions, no appointments, no cost beyond a pillow, and it addresses a stroke risk variable that nothing in your current medical regimen is touching. I think about the patient from that 247 call more often than I talk about her, not because the outcome was the worst I have seen, it was not. She recovered partially. She regained most of her speech. She went home to her husband. But I think about the 8 hours before, the position her body held through the night while a cascade of events developed in silence. Whether a different position, a body pillow, a different pillow height, a conversation nobody ever initiated might have altered what her husband found when he came downstairs. I cannot answer that with certainty. Medicine is humbling in that way. Causation in a single case is never clean. What I can say with certainty is this: the mechanisms are real. The research is consistent, the intervention is free, and the conversation has almost never happened for the majority of seniors who need it most. You now have that conversation. You have the mechanism, the research, the protocol, and the 3 clinical questions to bring to your next appointment. You did not need a new prescription for this. You needed information, and now you have it. Complete clarity before you go. Sleep position directly influences 3 physiological systems, with documented stroke relevance in adults over 60, cerebral venous drainage through jugular vein dynamics, glymphatic waste clearance efficiency, and nocturnal blood pressure stability through airway positioning. Left lateral sleeping produces superior outcomes across all 3 systems compared to supine or right lateral sleeping. Studies show up to 25% improved glymphatic clearance, better nocturnal blood pressure profiles, and reduced morning surge magnitude. 3 hidden setup errors in your current sleep environment: pillow height, arm positioning, and unrestricted nocturnal rolling may be preventing you from maintaining the protective position, even if you begin the night correctly. Your 3 actions beginning tonight. 1. Begin tonight in the left lateral position. Place a firm pillow or rolled blanket behind your lower back as a passive rolling barrier. 2. Check your pillow height, lying on your side ear level with shoulder. Adjust tonight if it is off. This costs nothing. 3. Write down these 3 items for your next appointment. Nocturnal position-related BP spike review on ABPM. Positional airway dynamics sleep study if you have any TIA or stroke history. Glymphatic optimization discussion as part of your stroke prevention strategy. Has your doctor ever asked what position you sleep in? Have you ever had that conversation in a cardiovascular or neurology appointment? Tell me in the comments. I read every single one, and your answer matters to the people in this community who are asking themselves the same question right now. If this video gave you something tonight, please share it with one person over 60 in your life. A spouse, a parent, someone who has had a TIA and has never been asked about their sleep position. Subscribe to Dr. Ryan Foster for evidence-based cardiovascular content built specifically for adults after 60. There is much more important ground ahead. Everything shared today is educational information grounded in current neurovascular and cardiovascular research. It is not personal medical advice. Before making any changes, especially if you have existing cerebrovascular disease, cervical spine issues, or sleep apnea, speak with your own physician first. Your brain has been working for you faithfully through every night of your life, every sleep cycle, every hour of maintenance and repair, every quiet act of clearing and restoring. Give it the position it needs to do that work. Tonight, just start there. I will see you in the next video. Take exceptional care.